Good afternoon, and thank you for joining us today for the impact of COVID-19 on individuals with disabilities. We're joined by health professionals from multiple fields, including physicians, faculty, students, trainees, social workers, administrators from across multiple organizations in community and within the academy. A little bit about today's webinar. It is being sponsored by the HMS Office for Diversity, Inclusion, and Community Partnership. Here at Harvard Medical School, I direct this office. I'm Dean for Diversity and Community Partnership and a professor of medicine here at Harvard Medical School. Our office's mission is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. Today's webinar, The Impact of COVID-19 on Individuals with Disabilities, is offered through our DICP Equity and Social Justice Initiative. It is the third ESJ webinar in the current academic year. In the fall of 2016, a planning committee comprised of faculty, students, and staff representing the HMS community discussed the establishment of an equity and social justice series to address health disparities, social determinants of health, leadership, health system, health policy, and other areas affecting vulnerable populations. Since 2016, an average of 10 to 12 programs has been provided annually in collaboration with our HMS affiliated institutions. ESJ events focus on 4 areas: history and context, culture and environment, health disparities, and the 4th, leadership and skill development. This year, the ESJ lecture series tackles health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers will address not just defining the disparity, but will discuss interventions on community, hospital, and policy levels to address inequities. Dr. Alden Landry, who coordinates our office ESJ discussions, will share more on this in a moment. A few housekeeping notes as we begin today's section. The chat will not be available. Your mics will be muted, but you can use the Q&A function to post questions to panelists. This is being recorded and will be posted on our DICP website. It's now my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He's assistant professor of emergency medicine at Harvard Medical School and assistant dean of the Office for Diversity, Inclusion, and Community Partnership. I'd now like to turn the program over to Dr. Landry.
Thank you, Dr. Reed, for the introduction, and thank you for your vision in helping us move forward with our Equity and Social Justice lecture series. I'm very excited about this afternoon's program. I think we have some amazing speakers who are going to bring some insights into our discussion around COVID-19. As Dr. Reed already mentioned, the ESJ series will continue to address a number of issues surrounding this virus and its impact on vulnerable populations. Today's program will not only talk about how the virus is exacerbating existing disparities, but we're also going to talk about how we can expand efforts and care to make sure that all receive equitable and high quality health care. As Dr. Reed mentioned, I will introduce our panelists, and then afterwards we will have a Q&A session with the panelists, and then we want to make sure that the audience is involved, so please be sure to use that Q&A function to ask questions either directly to a panelist or at large to the entire panel. And then lastly, when we wrap up, there will be a very brief survey that we'd like all of you to participate in, just to give us feedback on how we can increase the exchange of information for the work that we're doing, and also look for opportunities to share more topics that need to be discussed when it comes to COVID or other issues related to equity and social justice. So with that, I would like to introduce our panelists. First to introduce is Dr. Lisa Iazzoni. She is a professor of medicine at Harvard Medical School and is based at the Harvard Policy Research Center Mongan Institute at Massachusetts General Hospital. We will follow up with Tatiana Ribeiro Saab, who currently works at the Boston Center for Independent Living, where she oversees information referral department. She is also the manager for the Dorchester program and is leading anti-racism efforts for the organization. And then last, we'll have Sharon King, who also works at the Boston Center for Independent Living as a community outreach specialist and has worked in the disability community for over 10 years. And she also created a support network called Liddy LIGO, which maybe we can talk about towards the end of the discussion. So I want to go ahead and jump right into our discussion with our panelists, and I want to go to you first, Lisa. Can you just give us a brief overview of the disability disparities and focus on how COVID has potentially exacerbated those disparities?
Certainly, and Alden, I just wanted to start first by self-identifying as a person with a disability. I've had multiple sclerosis for 44 years and I've used a wheelchair since 1988. And so this is kind of really real world stuff for me. The phrase people with disabilities, though, is kind of almost a meaningless term because disabilities are so diverse. And it's also important to note that disability is one quote unquote minority group that anybody can join kind of in a flash. I don't want to be too graphic about it, but if somebody just walks across the street and happens to run into a bus, there you could have a disability. So I think it's also important to note that disabilities are common. About 25.6% of the population, or 61 million Americans, have disability. And so this is something that across the lifetime, almost everybody will have at least some sort of disability. Some people might not, but across the lifetime, almost everybody does. So the rates of disability are slightly higher in women than in men. And I kind of am starting with demographics because there's an incredible intersectionality here with other groups that experience healthcare disparities. For example, disability rates are 24% among whites, 30% among Black Americans, 31% among Hispanic people, 16% for Asians, 25% for Native Americans or other Pacific Islanders, and 40% for Native Americans and Alaskan Natives. Now, in terms of disparities, it's really important to note that people with disability also, on average, really have high rates of social determinants of health disadvantages. They're much more likely than other people to have low incomes, low education, high unemployment rates, poor housing or housing insecurity, significant transportation problems, food insecurity, and also more likely to be the victims of domestic violence or intimate partner violence. And that's not just for women, but it's also for men with significant disability, that they are at risk of those factors. It's pretty well documented by now over the last couple of decades that people with disabilities experience disparities in screening and preventive services. They experienced disparities in wellness care, cancer care, pregnancy and prenatal care. It's typically considered that people with disabilities are not sexual beings or interested in reproductive health. And so often doctors just don't even talk to them about contraceptive needs or sexual health needs. Also, patients' experiences with care, their ability to communicate effectively with clinicians, and respect and dignity being given by clinicians is reported by patients with disability to be lower than for other populations. And I just want to report on some kind of breaking news results from a survey that we just recently did. It's probably the first ever national survey of physicians who practice medicine in the United States about their experiences with and perceptions of caring for people with disability. And we have a lot of results from that that I don't have time to go into, but the top line result that I just want to report for our conversation here is that 83% of physicians reported that they view the quality of life of people with disability as worse than the quality of life of other people. So if you go into things with physicians thinking that my quality of life is worse than the quality of life for other people, you can readily imagine that if it's not explicit bias, it's implicit bias that is also very, very often kind of driving the clinical decision making that physicians might be making.
Thank you for sharing that. And thank you for sharing specifically about the physician bias. And I think that's a part of this conversation that we definitely need to dive into a little bit more. Can we get a little bit more specific around COVID-19? And can you talk more about the concerns about that people with disabilities have relating to becoming infected with the virus?
Sure. Okay. So I want to kind of separate this into three different settings. Okay. I want to talk about the hospital setting, the long-term care setting, or congregate housing setting, and then the in-home setting, because I think that the issues are very different across the three settings. So people with disability, and we'll talk about this in a second, Dr. Landry, when we talk about crisis standards of care. But in terms of coming into the hospital, if people with disability come into the hospital, often they're disadvantaged in general in going to the hospital because there aren't height adjustable examining tables, there aren't accessible weight scales, they often can't get access to diagnostic imaging equipment. So from the very get-go, people with mobility disability, especially coming into hospitals, are disadvantaged. People with communication disability, people who are American Sign Language users, who are deaf, culturally deaf with a capital D, often American Sign Language interpreters might not be made available to them. People hard of hearing who lip read, who rely on seeing people's lips and facial expressions to be able to communicate effectively. If every person around them, not just physicians and nurses, but also food service people and everybody else, are wearing masks, they might have trouble communicating because they can't read lips. And then another thing for people in the hospital, we all know that friends and family members are not allowed to come and visit patients, but often people with significant disability, especially mobility disability, and some people with autism and other disorders, have support people that assist them with even the most basic kind of activities. For example, if you're quadriplegic and cannot move any part of your body from your neck down, you are going to need assistance for almost every physical activity. And so if the support people are not allowed into the room to care for the patients could be in really very deep trouble. And so I think that what I just want to say is, just like everything else with the pandemic, um, the um, the COVID pandemic and hospitalizations just exacerbates and lays bare all the other disadvantages that people with disability confront in getting healthcare. They ordinarily have access problems. In the pandemic, they have even greater problems. Then the second area that I wanted to mention is long-term care settings, because often people with disability who are unable to live in the community for whatever reason live in long-term care settings or congregate care settings. And I'm not sure what the current statistics are, but back a little while ago when I was looking at the statistics, about 60% of the deaths in Massachusetts had been from people in nursing homes or congregate living facilities. And we know what the problems are. These are people who cannot socially distance. They're often cared for by staff who may not have adequate PPE, may not be trained in infection control. And so and also, just as in the hospital, family are not allowed in, or friends are not allowed in, to be able to advocate for these patients. And so we see just incredibly tragic and devastating rates of deaths, especially in congregate living facilities for people with disability. And then finally, a lot of people with disability, even significant disability, live in their homes and in communities. And they might rely on what's called informal caregivers. Those are basically people who aren't paid, their family, their friends, people who because they're your family, that's what you do, you care for them. But those family members might not have PPE, might not have protective equipment. They have to go out into the community to do the grocery shopping, to do the other things, just as might the formal caregivers. You know, about 16% of care is provided by formal PCAs who are paid for their care. And they might get exposed in the community to coronavirus and come in and not have adequate PPE. And so people with disability who live in the home, who may be sequestered in the home, may stay in the home, may self-quarantine in the home, nevertheless need to have people coming in from outside who can bring the coronavirus into them. And then once the coronavirus is in the house, they might not have the adequate protective equipment to care for other people coming in and out. And so, there's also difficulties with testing home care workers, especially early in the pandemic. Home care agency workers did not have adequate PPE to go into the homes. And so if people can't drive and they can't get out and they can't go to get tested for coronavirus, they might not even be tested and know that they have the virus. And so I know that Tatiana and Sharon are going to be talking about some of these things. And I promise you guys, you'll have a lot more kind of community-based stuff to talk about. So I didn't steal your thunder, but I just wanted to make sure that these are kind of top level concerns.
No, and thank you for that, because I think it helps to paint a better picture of where we're at. And one of the things that we've talked about in many of our conversations around COVID-19 is that multi-generational home, the need for multiple individuals to be in a shared space, the limited access to PPE for individuals working in aggregate living situations, group homes, nursing homes, things along those lines. So I think that just is part and parcel with everything that we've been talking about in our prior discussions. You hinted at this, and I wanted to make sure we have a conversation specifically around crisis standards of care. This was a concern that came up early in the pandemic about access to ventilators, and you mentioned conversations around quality of life and how doctors may perceive individuals with a disability as having a lower quality of life, and how that may come into play when discussing who gets access to certain interventions or certain levels of care. So can you just talk about what you have seen and how we can best prepare to be equitable in when we think about crisis standards of care?
Yeah, okay, so I assume that most people probably know what crisis standards of care are. As healthcare professionals, you're aware of these. It's usually these are set up by the states. Typically, they're supposed to be established when there isn't an emergency, so you can involve stakeholders, so you can get everybody in the community in, and so everybody can kind of participate in coming up with crisis standards of care that kind of reflect the attitudes and views of the entire community. But that just didn't happen in this situation. And so, as Alden said, early in the pandemic, starting back in March, people in the disability community, especially since we are used to being disadvantaged, we're used to having discrimination, we're used to having disparities in care. And there was also kind of a concern among especially people who are ventilator dependent. There was kind of a sense going around that if there are ventilator shortages, somebody with a disability, they're just going to come in and take their ventilator away. And some of this might sound apocryphal to you, but what started happening was people like Michelle Mello, who is a lawyer out at Stanford and published an article and a perspective in the New England Journal in April, actually documented that crisis standards of care in some states actually explicitly said that people with certain types of disability could be put at the back of the line if they came to the hospital. And there were certain states, I won't name them, she actually names them in the back of her perspective in a very nice chart, said that people with intellectual disability could go to the back of the line. People with quote unquote functional impairments, i.e. people like me, who uses a wheelchair, could be put at the back of the line. And so Massachusetts started actually in kind of April, started convening through the governor's task force, started hearing concerns from people in the disability community and from other communities around the state, racial and ethnic minority communities, about how some of the crisis standards of care, some of the standard kind of the SOFA score, the sequential organ failure assessment score, that it might that was kind of the center of some of the measurement about physiologic stability, that some of that might disadvantage people with disability and other populations. And so I think that there's, in the state of Massachusetts at least, there's been a concerted effort to hear the voices of people with disability. And for the nation at large, the Office of Civil Rights in the Department of Health and Human Services in March had to issue a bulletin in late March about discrimination, that you cannot discriminate against people simply because they have a disability when there are times of shortage. And we fortunately in the spring and early summer, kind of as a nation, got through without ventilator shortages and without too many shortages in terms of ICU beds. But it looks like we are heading into a dark time right now, and that is not going to be the case, that there are going to be places around the country. And I don't know about Massachusetts, maybe we'll be spared, but there are going to be places around the country where crisis standards of care are going to be put into effect. And so I know that this is something that the disability community is really pretty terrified about. And so I just hope that that this is something that people keep an eye on. Sorry, my screen just died
And
on.
it's certainly something that we need to, as for those clinicians who are listening in, to be thinking about as well, just to make sure that we are being thoughtful in how we provide care for our patients. And I think that Massachusetts did do a good job of sort of reassessing their crisis standards of care in the interim. March, April, May was sort of a rushed effort, but I do know that the state put forth a concerted effort to make sure that many voices were heard when reestablishing their crisis standards of care model. I hope that we don't have to use that model. One last question for you, Lisa. Any thoughts on how COVID-19 itself might be disabling? We've only known the virus for the past 10 months or so here in our country, but sort of what you are hearing and seeing from patients who are diagnosed with the virus early on, and how they may be having some longstanding impacts with their overall health.
Yes, this I think is as yet not an untold story. It's certainly being talked about. There was an article in the Atlantic magazine quite a few months ago about the quote unquote long haulers, people who've had coronavirus, maybe not necessarily diagnosed, but they had the symptoms and it was hard to get a positive virus test on them, but it just really looks like they had it. And then some do get positive tests, but who long-term have what looks, for all intents and purposes, kind of like a chronic fatigue syndrome, or they might even have chronic delirium. You know, there's a COVID delirium. They might still have a brain fog. And so I think that this is the as yet untold story. And especially women who've had chronic fatigue syndrome have known for years and years that they're often dismissed, that their concerns are invalidated, that they're told there are no test results that can prove what this is. And especially for people who don't have a positive coronavirus test, but they have these symptoms, there is a concern that maybe it might not be recognized as such. But I think that there's also the potential benefit that for people who have had longstanding fatigue type syndromes pre-COVID, that now maybe people will go back and look at those again and say, look, we're seeing this in COVID as well. Maybe we can learn from the long-term effects of COVID to be able to inform some of our thinking about some of the other chronic fatiguing conditions that people have presented with over the years.
Wonderful. Thank you for really setting the stage for us, Lisa. I want to turn to you, Tatiana. I want to make sure that we have a chance to hear from you and Sharon. And so for you, Tatiana, in your role, you interact with people with disabilities on a daily basis. And I'm sure you've heard stories related to how COVID-19 is impacting their regular care. Can you share an example or two or how COVID-19 has disrupted the continuity of care? Oh.
Okay. Thank you. Thank you for having us here today. I'm really glad to be part of this panel. At the Boston Center for Independent Living, we are a civil rights organization that provides care, support and advocacy for people with disabilities. And also we run a personal care program for people with more significant disabilities. And one story, especially in the beginning, that we heard from consumers calling our assistance line was from spinal cord injury consumers reporting that they were unable to access physical therapy services during the first few months of the pandemic. And many of them were reporting developing serious urinary tract infections and other complications that could have been avoided had them have full access to the services that they had pre-pandemic. Another common story that we heard was from patients with acquired brain injury, where they couldn't have their support a person go to the doctors with them. And many times they would report they not remembering everything that was discussed at the office, and not quite being able to follow up on their medications correctly, and just being confused and overwhelmed with the following office visits or telephone visits, and just feeling very isolated on managing their health care, managing their health. So those are some of the stories that we heard in the beginning, and we put a lot of advocacy efforts on advocating for access, better access to life-saving therapy services and other services that a person needed to maintain their health. And yeah, so some of examples that we heard.
Yeah. You know, it's interesting. Maybe we can dive into this a little bit later, but I'd love to hear your thoughts about how switching to telehealth visits may have been helpful or harmful to individuals with disabilities, and sort of perceiving that regular routine care. But one question I do have for you now is, some individuals with disabilities have had their daily routines impacted by COVID-19, and it was partly alluded to by Lisa with the issues related to personal care attendants. Can you share a little bit about what you heard from your clients as it relates to access to personal care attendants, complications related to PPE for those individuals, or just overall just a loss of availability of those care attendants, or other impacts on their daily routine?
Absolutely. So this has been one of the biggest areas that we heard from consumers, is access to personal care attendants, right? They were in the very beginning, they're just afraid of having PCAs come to their house. So they didn't have, their daily routine was disrupted. People were going without a bath, a daily bath, because they were trying to curtail the number of people that were coming to their houses. They may not have had family members that were living with them that could help them with some activities of daily living. Just overall fear and accessibility. Also, because PCAs, they had their childcare disrupted. So the lack of childcare and the lack and schools closing affected just the number of PCAs that were available to provide essential care to consumers. Another fear that we heard from consumers was just the lack of appropriate personal protective equipment. And I think not being able to even purchase that in the beginning was just, they had no access to personal protective equipment. So the fear coupled with the lack of access really impacted people's lives. One thing that the state have done is that they have shared PPE with the Boston Center for Independent Living, and we became a depository of, we received over 50,000 masks but this was already late July. And then we've been distributing them for consumers that needed them, couldn't afford them, and just needed them for their daily livings. So, and we provide the personal care equipment to both the consumers and the PCAs. But that was not something that happened immediately. So the lag between March and July, there was a huge gap that was left. One thing that MassHealth tried to do was to allow PCA consumers to access care through home health care agencies. But even that, the waiting list for home health care services was a long waiting list. Also, the difference, because the PCAs are trained by the consumers and they're supervised by these consumers. They are, in essence, working directly for the consumer. With a home health aid, home health care aid, they report to an agency, and they might want to do things in a different way. And the consumers didn't have the same voice and the same ability to control the care that they were receiving and to inform the care that they were receiving. So that even though that was a measure that was put in place to assist with the lack of access to PCAs, is a system that's not perfect, and that left people feeling still vulnerable and not in control over the activities of daily living. Another issue reported to us was that people that didn't have PCAs and were receiving cares from family members, that there was reports of increased abusive behavior and violence in the home. People just losing patience, not denying some care, and just abuse in general. So we really did see an increase, and we have made increased reports for the Disabled People Protection Commission to investigate those instances and to see what could be done to deal with the reports that were coming in.
You know, as I was listening to you, what your response to my question, I was thinking about the layering effect of COVID-19 with the personal care attendants not having childcare for their own children, so they weren't able to go and do their jobs to help out to care for individuals living with disabilities, and how we often like to look at these issues as individually and not thinking about the larger systemic impact that this virus has had and the layering effect that this can have on communities, and how to get to the solution, multiple levels, multiple interventions must be done to ensure that our patients are receiving the quality of care that they need. I just have one last question for you before we move to Sharon. You mentioned this with, you touched on this with the conversations around abuse. Dr. Iazoni mentioned this briefly as well, but one of the things that we need to make sure we discuss in this conversation is the impact of COVID-19 on mental health. And can you share with me your thoughts on this space and how the mental health issues are popping up, and we're seeing different issues related to the mental health access to care for patients as well?
Absolutely. So in terms of mental health, I think just the isolation has played a huge role on people's mental health. We have seen increased reports and people seeking help that they were they fell off their medication, they were not having regular visits with their psychiatrists and with their psychologists, many people reporting that it didn't feel as comfortable in a telehealth setting, especially people that were only using the phone as a way to access mental health services, that they felt wasn't as effective. So we have seen an increase of people reporting that they're hearing voices. There's just paranoia. We had one consumer that had the locks on her house changed like 4 different times since the pandemic started, feeling like her neighbors were coming in or trying to poison her water, just paranoia in general, but really indicative of not receiving ongoing mental health supports that they had access to pre-pandemic. I received a call this morning about one of our youth consumers that actually attempted suicide last night and was in an emergency care room. She survived, thank God. However, she's now waiting for a pediatric psychiatric bed that she can move into, and meanwhile she's in an emergency setting that is not conducive to good mental health and to the supports that she needs to really to live a full life. So I think that tragic example just, is still happening, right? So it just reminded me again, the seriousness and the life and death situations that some of our consumers are faced with, that this pandemic, just things are happening so fast. We haven't had enough time to plan for a great access to mental health services. And what can we do as a group to really think through and to make sure that people are receiving the treatment and are also following the treatment plans and are taking the medication and have all the supports in place that deal with isolation. For such a big life of youth is school, and not being able to go to school and being home all the time. That isolation, how it plays and enlarges the problems that they're facing, and that feeling of hopelessness and isolation.
Well, as an ED doc, I can tell you that without a doubt, we are seeing the mental health complications of COVID-19. And one of the biggest things that we're seeing is what you just reported, is that individuals are coming to the emergency department with a mental health issue. And because of lack of availability of beds for inpatient psychiatric care, we're seeing patients with longer and longer lengths of stay in the hospital. And unfortunately, we're even seeing some cases where patients are contracting COVID-19 and emergency departments are in their inpatient settings, which makes things even more complicated. So thank you for sharing all of that. I just want to make one housekeeping note before we move to Sharon. The Q&A section is open. So after Sharon and I finish our conversation, I want to turn to the audience and try and address any questions that you may have. So be sure to use that function if you have a question for our panelists. But I want to go to you, Sharon. We exchange emails trying to tease out how to best have this conversation, because it's layered and complex, much like what we've been talking about before with Tatiana and Lisa. Can you share some examples of why people with disabilities distrust the healthcare system? And can you talk about specifically as to how the intersectionality comes into play when you layer on top race plus disability?
Hi, thank you again for having me, by the way. So historically, the healthcare system has been unkind to people living with disabilities. There's a history of things like being locked away, being called criminally insane, being called, basically being told that, you have a disability because you're immoral. There's a lot of a tumultuous history of treatment of care or lack thereof when it comes to disability. You know, facilities that are less than, that treat people like they are less than human. All of this has kind of contributed to the mistrust in the healthcare system in general. It's, you know, when it comes to race and disability, it's very similar where, you know, you hear the stories of people being experimented on, you know, whether the Tuskegee experiments are the most, you know, the most notable, where, you know, there's all of this mistrust because of a history that basically says what Lisa said, like, you know, your quality of life is not something that we consider, you know, quality. So there is a history of mistrust. There is a history of, you know, to this day where people go to the doctors and they don't feel heard. They feel like these doctors know what is best for me. Well, the doctors feel like they know what is best, so they in turn do that. Doctors are fixers. Doctors go into medicine because they want to solve problems. However, the disconnect comes when the doctors look at patients as problems and not as people. And when you don't feel listened to, when you feel like a project, when you feel like an experiment, it's hard to have trust and have confidence in your, you know, in the medical field. Race is definitely linked to disability when it comes to poverty and things like social determinants of health, which we'll talk about later. But I kind of lost my thought a little bit. But there are barriers that create poverty, you know, access, lack of education, this history of mistrust in the healthcare system. They're all things that contribute to the state of things now.
Yeah, you know, and it's interesting, as you mentioned, you know, when we talk about the history of medicine and physicians and their abuse towards historically disadvantaged or marginalized or vulnerable patient populations. And then you layer on top of it a pandemic where we don't have all the data and we don't have all the information on how to best approach this. And then there's all the other complications. And again, that layering that we've been talking about with our prior panelists, it just makes perfect sense that this is the perfect breeding ground for potential abuses of patients. And then more specifically, those distrusts that patients have to be more cemented and solidified because we hear of stories and of tragedies happening to patients coming from those disadvantaged and vulnerable patient populations. And I think one of the spaces that we're going to have to talk about is vaccines and access to care and sort of that level of trust that you were just mentioning. But you alluded to this in your last question. I want to talk back more about it. Talk more about the social determinants of health and how it's been impacted, or individuals with disabilities have been impacted by COVID-19 from a social determinants of health or social drivers of health as opposed to just the virus itself.
So yes, social determinants of health are conditions like your environment, where you live, where you work, where you worship, how you do things. Lisa actually made a very valid point about caretakers and how some people depend on family and friends, which is more so a cultural thing as well, which also stems from the mistrust of the healthcare system. So these are, you know, this is where the disparities come in, especially if we're speaking about COVID-19, where you have people that cannot afford to miss work. They can't afford to, you know, not show up, or they can't afford to be exposed because of their situations at home with their you know, loved ones. I had a situation where a family member did contract COVID-19. Luckily, I am employed in a place where I can be remote. But if I didn't have the choice, if I had to go to work, I couldn't imagine making that decision. And that is something that's very real and people face every single day. I've heard about it, and you know, people are so nervous about what it looks like, you know, when you have an administration that's giving you this information and then this information, and things are conflicting. you know, and it all kind of always is going to circle back to that mistrust. So when it comes to, you know, what you see often is, what I've been seeing often is people questioning if this vaccine is actually going to be valid, because it seems like it was developed in a very short time. And the question is, who are they going to experiment on? A lot of people really expected, like, we're seriously expecting experiments to be conducted on people of color first. So that's a really real concern. And also the validity of the COVID-19 pandemic. And like, some people really still think that this is not a real thing. And it's scary, you know, especially as someone who has experienced and watched it firsthand, for people to really still operate as if this is not very serious. So it's hard.
Yeah, and I hear the despair in your voice as you talk, and you know, I think there's a lot of misinformation that's out there related to the virus itself. Unfortunately, coming from places where we should be able to trust information. I also think there's a lot of misinformation about the vaccine and its safety and efficacy. I think it's interesting as we really tease out the data as far as who was involved in the vaccine and the trials. You know, you see the numbers where there are fewer minorities involved in those studies than we would have hoped to have seen, to ensure that that we're looking at all patient populations involved in the study from an equitable standpoint, and making sure that also there's going to be fair and equal distribution is also a concern. Obviously, if you look at the numbers, there's certain race and ethnicity groups that are less likely to take the vaccine. And I'm sure that may be a concern in the communities of individuals with disabilities. I have one more question for you before we try and maybe answer one or two questions from the audience. Can you talk briefly about just the still ongoing issue around access to testing, specifically free testing for individuals from underserved communities and for individuals with disabilities? And do you have any suggestions on a way to make testing more readily available?
So as far as gaining access in these communities, you know, some of the communities on my shirt, Roxbury, Dorchester, Mattapan, and Hyde Park, these are high minority immigrant populations. I like to follow a lot of the local politicians and city councilors and things like that, because they often have info sheets that they post, which I like to repost and redistribute. Liz Miranda is always posting about free testing sites. I know that the Bowdoin Street Health Center was doing some free testing. Also, if you go to the Public Health Commission's website, they literally have a list of free testing sites, information lines. Let me see if I can pull up and give you the actual share the website with you.
Well, maybe we could do this in our post communication with the audience. We can share that.
Yeah, but yeah, really it's about reaching out to your local organizations such as the Boston Center for Independent Living for this type of information, and using your community resources to really, I mean, that's really all we can do is support each other and share information and educate each other about what's going on and how it affects us. But yeah, it really, for me, education is what resonates with me. If you know what's going on, if you're aware of what's going on, you can take the proper steps to, you know, prevent it, protect yourself and others. So yeah, reach out to your local community organizations, your local leaders, and definitely share as much information as you can.
And I think just to stress that it's important that this problem is multifaceted. And in order to address the issues that we're identifying with COVID-19, we have to engage multiple stakeholders. All those public health buzzwords that we often talk about, now is actually time to pull out that playbook and actually use it. And if it's not in the playbook, time to get creative to make sure that we're engaging these vulnerable communities. All right, I just, because of the time that we have, I want to say thank you to all three of our panelists. We have a couple questions in the Q&A, and so I'll turn the first one to you, Lisa. If you're still here, can you just talk about the issue that you brought up about limited hospital visitation and how that may be impacting patients. And then also, are there any policies that are in place or is it just on a hospital level in order to try and mitigate this concern, and so that patients from vulnerable backgrounds and individuals with disabilities can't have access to family members?
Okay, so Alden, thank you. Yes, I saw that come up in the Q&A, and it is true that this issue was really a big problem at the very beginning, but it became pretty clear that actually having people's supports in the hospital can help the hospital staff as well, because they're not having to deal with some of the very basic needs that somebody with a disability might have if they're hospitalized with COVID. And so, in fact, my institution, which is Mass General Brigham, is just now putting together a very clear policy saying that people who are officially designated by the patient as their support people are to be allowed in care settings in the context of COVID, because that is what is considered under the Americans with Disabilities Act a reasonable accommodation. These are people who are not just casual friends or casual, acquaintances. These are people who are actually providing support and assisting them. And so I'm not sure what the situations are in other healthcare settings. I haven't heard that there's a national policy about this, but this would be something that would probably fall under the Americans with Disabilities Act, that allowing a designated support person to assist a person with a disability should be considered a reasonable accommodation. Although obviously those people are going to need the PPE and the protection as well to make sure that they don't come in contact with, the coronavirus.
Mm-hmm. Yeah. Again, it's that layering, because this is a multifaceted situation, and we need to make sure that we're thinking about this from all different perspectives to ensure that everyone is safe. Just a quick question for you, Tatiana. How do you envision, any changes or any issues that are going to be sort of longstanding chronic issues for individuals with disabilities after we get through this pandemic?
I think, what we are seeing is just access to food, right? Access to housing. I think the pandemic made it worse, but especially with whole families staying at home. I was talking the other day with a mother that has three children with disabilities, and the difficulty that she's having to keep them fed. And she said, I can't go to the designated places to get food for my children for school lunches because of their disability. And Boston Public School in the beginning was not delivering the food to now they are. They're delivering the food to students with more significant disabilities. They're delivering their lunches, which helps a whole lot. But I think we're going to continue to see access to food, to mental health, to adequate housing, especially accessible housing. I think those are challenges that are going to stay with us after COVID.
And it's interesting because I think we've learned a lot from the virus and how our health system works, but we also learned a lot of the holes in our systems. And that's goes beyond even addressing those social determinants of health and being more upstream with our intervention. So I agree. I think we have some chronic issues that we're going to have to deal with, and we're going to have to grapple with as on a state and local level, but also on a federal level as we think about how individuals with disabilities or other vulnerable populations can be left behind in situations, normal times or in pandemics. And then I have one last question that I want to touch on, and I'll toss this one to you, Sharon. As we think about COVID-19 and the fear and the mistrust that you were discussing, there's and then also the social determinants of health issue that you were talking about. We do rely a lot more now on telehealth and trying to address concerns for patients with disabilities. Can you talk about how that is sort of borne out in the maybe widening the disparities or lessened disparities in what you've seen?
I really don't have a lot of information as far as telehealth, but For some, it does seem like a blessing. For some, people are frustrated that this is something that all of a sudden can happen now, but when I was requesting it before, it was an issue. So I think that also it definitely contributes to the mistrust, which is the ongoing theme. But for me, for someone like me who lives with multiple disabilities, I have a stomach condition that we're literally in the process of trying to diagnose. And the specialist that I went to see is only available via video. Now, I would prefer to go in person, but I am, grateful that though there is a pandemic, I can still see this this professional. So it's really subjective. Some people feel slighted. Some people feel slighted, but they are relieved that they can still receive care. And some people are just rejoicing that this is easier and a step forward. And honestly, I think that this is it's definitely going to stay with us going forward. I think I feel like it's an effective way to otherwise compensate when you absolutely in a situation like this, in a pandemic where you absolutely cannot see your healthcare professional.
I mean, and you're ending us on a very solid point in so much that, you know, it took a pandemic for us to realize that there were multiple ways to reach patients. And I know that those vulnerable communities that would have preferred telehealth for years, once the technology was available. And now that it is, we're relying on it so much, but why couldn't have this been done years ago? So I just would ask if we could just pop up the poll questions that we have for our remaining audience. If you can try and answer these questions quickly for us, we'd appreciate that. And it's only 5 questions. If you have recommendations for us for further topics to consider for our equity and social justice lecture series, whether they're germane to COVID-19 or other issues, please let us know. I want to say thank you to our speakers, Dr. Lisa Iazoni, Ms. Tatiana Ribeiro Saab, and Ms. Sharon King. I want to say thank you to all of us, all those who joined us for this presentation, and to Ying Wang and Dr. Reed and the rest of the DICP staff for helping us to execute another webinar. We look forward to seeing you again. Happy holidays to everyone, and we will see you in the new year with future iterations of our equity and social justice lecture series. Thank you.